You've been in the mental health care system for some time now. What's the most troubling aspect of it, in your opinion?
That's easy. Access. There's not enough access to mental health care services in Canada, and that, ladies and gentlemen, is
Dysh, 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 dysh.
Hey y'all, it's Onika,
And J.R.?
and you are dishing with Dainty Dish. How you doing, J.R.?
Probably better than you.
Why do you say so?
I don't know. That was just something that I thought of. There's no real reason for me to say that. I'm doing all right. I'm just doing good. I am trying to make some money and so that I can stay living in my beautiful place.
Of course.
You know, that's what I'm about right now. So, yeah, I'm doing good.
That's good.
I'm on a little hiatus from my dodgeball. I'm still up at yoga, keeping active, you know.
That's really good.
So how you doing? What's going on?
I'm doing well. Well, I'm doing better than well, because well is a deep hole. But I love saying that. It's one of my favorite sayings.
Why did you wait till you started talking to then decide to drink some water?
Because I had a tickle in my throat. There was a tickle.
So you didn't know there was a tickle before?
No, I didn't know there was a tickle before I started talking, right? So I just waited to drink some water. There was a tickle.
Oh, okay. Just wanted to make sure.
But
Okay.
as I was saying before,
Yeah, go ahead.
I'm doing really well. Actually, work has been just insane with the holiday season. I'm hoping it ends soon. But I've been getting a lot of hours, which is really great for the bank account. Other than that, though, outside of work, I actually got involved with a collaborative workbook, mental health workbook focus group the other day, and it was really very, very productive. But it got me to thinking about access.
Define
Accessibility.
productive.
Well, I would say, because we can't really talk too much about it, it hasn't come out quite yet.
Yeah.
So they're performing focus groups right now to put it together, but it's kind of like a mental health 101, like what to do when you're having mental health issues and where to go.
So you're developing curriculum?
It's not a curriculum necessarily. It would be found in physicians' offices, like some of the places that they were suggesting would even be, we suggested schools as well. But it's almost like they talked about the initial appointments, follow-up appointments, your rights, what your rights are, things like that. So it's kind of like a first point of contact when you're having mental health issues, but they're trying to decide where to disseminate it to. Like, where to hand it out to. Should it be in the doctor's offices? Should it be in the subways? Should it be a pamphlet? Should it be a booklet? So all those decisions still have to be made before the workbook comes out. But it's something that's happening through St. Mike's Hospital. And I was really grateful to be a part of it. Because it's policy changing. Like, it's about changing the policies when it comes to mental health and accessibility. And having access to those services that we need. Which I think is sorely, sorely lacking. And I'm actually going to be doing another dialogue with this group called Converge 3 in January, where they're also working on guidelines and policies for mental health. So it's exciting stuff. I'm really happy to be a part of all of this. It's going in the direction that I want to go in, which is changing the face of mental health care in Canada and making services more accessible to people that don't have the access. And today, particularly, I wanted to talk about access because I want to talk about our youth. Right now in Canada, they're saying that there's about 20% of young people that go through mental health illnesses and disorders, but the services are sorely lacking. Their first point of contact is supposed to be their physician's office, but they're finding themselves going to emerge a lot.
Okay. Do people have physicians? Like family physicians? I don't know.
That's another thing. That's another thing. There's walk-in clinics. A lot of people, like the immigrant population, for instance, might not have a dedicated family physician to go to, so they're taking their kids to emerge. And there's actually a study done in 2017, very recently, and I wanted to talk about that study. It was through the Center of Applied Research in Mental Health and Addiction, so CARMA. That's what we're going to call the nickname, just because that's how it's spelled, CARMHA, where a team of mental health specialists and addiction specialists came together to do a study over over 5 provinces. So they studied BC, Alberta, Manitoba, Ontario, and Quebec. The things they were looking at was the regular access to physicians for youth diagnosed with mental health and or addiction. That's number 1. So there's 6 pieces of information they were comparing. Number 2, whether first contact for mental health and addiction is happening in emergency rooms. The physician follow-up after hospitalization. Suicide rates for young people diagnosed with mental health and or addiction. Suicide attempts for people diagnosed with mental health and addiction. And the mortality of those diagnosed with mental health and addiction. So they did a really thorough study of these 5 provinces. And what they're finding is, for instance, in Manitoba, they had high rates of physician access, which was good, but a low percentage of first contact in emergency rooms, which actually is a good thing. But they had a high rate of suicide attempts. That could also be attributed to the Indigenous population that lives in Manitoba, because there are high rates of suicide amongst the Indigenous population.
Yeah.
In Ontario, they had a low rate of suicide attempts. In BC and Alberta, they had the best physician follow-up after hospitalization. In Quebec, it was the first contact in an emergency room was very high in Quebec.
Okay, so you're jumping all over the place for me, because I know how studies are written, and I know how people gather stats when they're writing them, but I just really want to get to the point of this. In Ontario, where we are,
let's focus on Ontario.
No, not in just focus. I just want to ask specific questions about it. Did the study say that? Where is our problem here? Are we having a problem with young people not having access to a physician? Are they going to the emergency room too often?
The biggest problem is the access to physicians and having to go to the emergency room for their mental health care. So they're saying youth ages 10 to 19 all across provinces are going to emergency rooms for their first point of contact for mental health care.
Okay, and the problem with that is?
The problem with that is they're not getting early detection. There's no early detection. So they're already in a crisis when they're in the hospital.
But if you're in a crisis, isn't the best place to go the hospital?
You don't want to get to the point of having a crisis. So let's use me as an example. Let's use my bipolar as an example.
Okay.
So when I was struggling with depression, I went to my physician, as my mom had said in the episode that we talked to her when we had the conversation with her. I went to my physician. I asked for a psychiatrist to speak to. So It took a couple of months, but I got a psychiatrist. Then fast forward to when I was bipolar. I had to have a manic episode to go into the emergency room to get mental health care. I wasn't receiving physician help. Physician from my family doctor. I didn't receive help from them. I mostly received medication that didn't work. And you just don't want the first point of contact to be the emergency room.
Okay.
You want to get early detection. So for things like depression and anxiety, you want to deal with the problem before it starts or when it's just starting, not when it's escalated to the point of suicide attempts, or, which again is one of the things they talk about in their report. You want to reach people before.
Okay, so I just want to let's talk about your situation, because that's the one I'm most familiar with.
Yeah.
So there was early detection because you said there was something wrong with you, and you went and saw a psychologist, right? So there was early detection. Mm-hmm. Now, something was diagnosed and you were given medication. The medication didn't work, or it wasn't resolving whatever issue.
It wasn't resolving the issue.
Okay. You then moved off to school and you continued. The recommendation from that physician was to see another physician.
And I did.
And you did.
And I did.
Okay, so you were still seeing a physician.
Mm-hmm.
So there was early detection. Like you were seeing a physician. There was early detection. There was something that was. You noted something was wrong. Your parents noted something was wrong. You were in the system trying to receive help. So, what went wrong? I'm because I don't like. I want to just with you in your specific situation.
Yeah, I would say honestly, I'm a rare case. We all know that self-advocacy is a really big thing for me. It's a huge thing. I do it when it comes to my mental health care. I'm an advocate for myself. I've had my parents advocate for me as well, but not everyone has that. So when you're dealing with mental health issues, and they talk specifically about depression and anxiety, you want the physician care before you get to the emergency room.
Where was your access problem? Like, where was the disconnect in the access that you received? That in your situation, you're saying, okay, there's an access problem because I'm like, there's a jump between you're seeing healthcare professionals, and then you're in the hospital, you're in the emergency room. What happened between seeing the healthcare professional and be on pace to have early detection, and then having this this episode where you are in the emergency room? Like, what happened in between those two? Like, was there a disconnect? Did you stop seeing your physician? Was what was happening with the physician not giving you the results that you wanted, and you needed to find another way, and it was not? There wasn't enough. The physician wasn't doing what you thought was necessary. Did you find something else to substitute? Like, what led to the drop from the early detection to that manic episode in the hospital?
I would say,
and where in that space, how can we grow the advocacy and figure out how, like, from that situation, how can we develop advocacy from there?
I would say, with mental health care and just the healthcare system, the sector seems to be a little bit broken. You go to your family doctor, you'll tell them you're not feeling well, you have a problem, and you think it's related to your mental health. Then the doctor places you on a wait list to see a psychiatrist or a psychologist, depending on your age. It could be a child psychologist or an adult psychiatrist if you're older. You're put on a wait list, anywhere from 6 months to a year. Whilst that is happening, your physician, who isn't necessarily well-versed in mental health, will give you a medication. It's often things like Seroquel or Cipralex, common antidepressants, to kind of solve the problem in a temporary way until you can see an actual psychiatrist or a psychologist or get the actual mental health care that you need. Now, whilst that episode is happening, or whilst you're going through what you're going through, and you're taking medication that you don't even know is necessarily helping you, there's this long wait time. So you're waiting for your psychiatrist to sign you on to get in to see a psychiatrist. Let's say now you feel so bad, you try to attempt suicide. Because this is a reality. This is one of the results of things like depression and anxiety and even bipolar or schizophrenia. So you attempt, let's say you do an attempt to commit suicide. So then now you're at the emergency room. So Emerge is taking care of you. They now have to connect with your physician, who might not have followed up with you only enough to give you medication. They're not talk doctors, and you need a talk doctor. Go ahead.
Oh, I'm just when you talked about that experience of going to the doctor and the family doctor and such, I just remembered that I did about maybe almost now it's about a year and a half ago. I did the same thing. I walked into my just to kind of see if where I can make a comparison. I walked into my doctor's office, said I need to talk to somebody. This is what's going on. I mean, he immediately asked me, "Are you thinking of committing suicide?" And I was like, "No, it's not that serious. It's not that serious, right?" But he asked the question, and then he asked me, "Am I looking to speak to someone, or am I looking for drugs?" Right? And I'm like, "Drugs? Drugs? Whoa, bro! It's not that serious either." So I mean, And I think if that's the standard,
that is the standard.
If that's the standard, so you're given an option of whether you want to take drugs or not take drugs.
Mm-hmm.
And a lot of times, maybe you're not really in a situation there where you're making the best decisions.
Yeah, you might because you're not informed. You don't know anything about mental health care.
You don't know anything about mental health care.
You don't know how to navigate the system.
And something that I've become more recently aware by just through this podcast and some of the guests, because even though we have the podcast here, we typically talk to the guests beforehand, like here, just with the mics off, sometimes before and sometimes after. And something that something that I don't know if it's ended up on the show, but they've told me that some of the side effects of some of these medications are suicidal thoughts and
yes.
such. So
voices, hallucinations.
So I'm like, Is there a problem in the education of I'm not trying to knock anybody, doctors at all, but is there maybe something missing in the education of healthcare professionals, so that maybe there's not really maybe a healthcare component to all the different I don't know if it's it's not designations. They have
diagnosis?
No, the different areas of expertise that different doctors have. So, like, you have like a cardiologist, you have a respirologist.
I think it's designations.
I don't know. Well, let's call it designations. Is there maybe not a mental health component in each designation? Like, does a surgeon learn to have to do? I don't know. Maybe they probably do.
I've talked to a couple of my coworkers who are in early childhood education right now, right?
Yeah.
And they tell me they do like a course on mental health. If they're not doing a stream where they're doing things like working with kids with autism or anything like that, if they're not doing a stream,
yeah, but I'm talking about like doctors.
No, but with doctors, they learn a little bit about everything.
No, but doctors learn a little bit about everything.
Doctors learn a little bit about everything, just enough to get by. Because they're not psychiatrists and they're not psychologists, so they don't necessarily know what to do. They're playing around. They're kind of playing Russian roulette with.
That's not where I was. Where I was going with it was that if the doctors, like mental health, are you able to make the right decisions, regardless of whether it has something to do with your mental health, something else? Like, our bodies go under stress in stressful situations, and we might have to make a healthcare decision about ourselves or about a family member. Mm-hmm. Are doctors trained well enough to understand that this person's in a stressful situation and they might not be thinking as logically as they might be in under normal situations, like they're under duress right now? That's where I was going with it.
Okay.
I'm just asking that question. I'm not trying to like ask blame or anything like that. I'm just like saying, is this a possibility? Like maybe because for me as a regular citizen, I don't know much about mental health, and if I didn't have, you around, and like I wouldn't know about access. I wouldn't know anything about it. Like I honestly, I probably wouldn't even care.
Question for you. How long was it before, between seeing your family doctor to getting a psychiatrist for yourself, how long of a period of time was that?
I went to a psychologist. No drugs. So
no drugs.
It wasn't that long. It was like, if I had returned the phone call, it would have been like a week or two. But I didn't return the phone call, and then I went away for like a month. Mm-hmm. So it was, but they would have, as soon as I actually returned the phone call, like they were able to fit me in like pretty quickly. So I don't know, that was my experience. So
and what is your like healthcare package like? Do you have like a healthcare, like a insurance package, or
what do you mean?
Like my healthcare comes from disability.
Okay.
Like that's where I get my medical insurance from. Disability.
Yeah.
So if you're on something like disability, or you are a part of an immigrant population, or you live in a rural area, or you're First Nations and you don't have access to certain things, you're not waiting 2 weeks. Like your situation is unique, I think, because of not who you are, but the level in which like your healthcare provider gave you service.
This was at the time I had no healthcare. This is all me. Like this.
Did you pay for it?
There was certain part of it that was covered through OHIP, and then after that, it's basically on me. And at that point, I was like, I'm gonna go pay.
Yeah, you might not have known all the resources, but you had the money, and a lot of people don't have the money.
And I was making sacrifices in my life that allowed me to afford that at the time. But it is expensive. But I mean, is there really a price you can put on your mental health?
There is when you're poor.
There is, and
when you're living in poverty.
And you say that all the time, and it's something that I always seem to just kind of glide over. But it's a real
thing. Like when you're living in poverty and you have a mental health issue, you are put on a 6-month to 1 year waiting list for a psychiatrist or a psychologist.
I can't imagine, because even though, like, for me, seeing the psychologist was just it was more just reassuring my own thoughts and where I was already headed. But I couldn't imagine not seeing that person, because that kind of just put me. It kind of like got me to go push through way faster than I probably would have had I not seen a professional.
Because you're talking about, like, we were just talking about minimum wage and what's going on there, but you're talking about $150 to $200 sometimes a session for an hour.
Oh yeah,
it's expensive. If you're purely relying on OHIP, which is the government, you're not getting the access that you need right away. Mm-hmm. Like, mental health doesn't wait on life,
and that's
like, it doesn't wait. It doesn't. It's a real thing. It doesn't wait. You know, we can't just say, "Oh, you're depressed and you're potentially suicidal." You know, in 6 months to a year, we'll get you some help. We'll get you some help. So, you know, that's why people go to emergency rooms so much for mental health issues.
But is that the result of a surge in? Because I mean, typically we see trends before they happen, and we usually prepare for those trends. So, like, for example, for me, like, I saw a trend in technology, right? So I went to school for that, and now I work in technology, and there's a surplus in jobs at this current moment that allow me to stay afloat, right? Did the mental health care thing come out of nowhere? Did we not see it coming? Were there not? Because typically when you see those types of things coming, there's programs that get people into the field of learning, and then of whatever it is. Like, the schools create a program and pump people through. Here's the thing. And I was reading this article, and we'll put it in the bottom of the description. It was saying the need to address mental health and addiction in youth is so great, because early onset for things like, and the serious ones that youth go through are depression and anxiety. Those are the main ones that they're saying that youth will go through. And early onset of that is in adolescence, between the ages of 16 and 30. Like, so how do we battle that?
Education, and having maybe a public health campaign, like we have for smoking.
What is anxiety and depression in youth? Like, in children, like, where does it come from? Is it? I'm confused, because what could be so depressing outside of, you know, there's some situations where, you know, there's assaults and abuse and
bullying. Bullying
is a part of life.
But it's where the kids are bombarded with it right now. We were just talking about this when we were off air, like social media and bullying.
We were talking about it, and I said to you that, you know what, we're in a landscape now where, yes, you may be bullied, but you can also find friends from all over the world that you can connect with. So there's two extremes. Like, you can, yes.
But you're still in school 8 hours a day being bullied. Like, you're still in school. Like, you might find friends outside, and, you know, between the hours of 8:30 and 3:30 or 4:30 or whatever time school hours are, you're in school being constantly bombarded with bullying.
So is that... So, you know, what about... But then, like, you know, my whole thing about that is, like...
I know. It makes
like, your school... You live and you go to school with people based on your parents' income bracket, where they decide to live, and the school that they send you to. You may not have anything else in common with them, and they may not be anything to you once you go off and make your own decisions.
I know. Also, we live in a techie world. You're a tech guy. You know, we live in a techie world. Bullying is not just simply pulling a pigtail anymore, or pushing a guy off a swing, or it's constant. It's on social media. It's trolling. It's so many things, and these young people who don't know how to handle it.
But do you have to be on your phone all the time? Do you have to be I don't know, like, because I guess now me, like, I live for the moments where I can just toss my phone in the corner. And just,
but these are young people.
Yeah,
you know, their phones are attached
I
permanently.
can't.
They can have phones in classes, which I don't think should be allowed to have your phone in your classroom. Like, but they can have their phones in the classroom and outside of the classroom. So if, one girl calls another girl a slut and it goes viral, throughout the school, everyone's calling that girl a name. Everyone's getting on that girl's case.
And that's where you're getting the anxiety.
The anxiety, the depression, the anxiety of getting up in the morning every day to go into that environment. The depression you feel once you get out of that environment. Like, I'm not solely blaming it on bullying, but I think kids are going through so much more than I think that we went through when we were younger, because of things like technology and social media.
Nonsense. There's more. Every generation goes through more than the generation before it, but that doesn't mean that the generation before it didn't struggle, didn't have new things that were happening that were completely different from the previous one. I mean, so that's not an excuse.
I just think educating teachers and educating parents, doing a public health campaign for mental health, so that reaches into families and schools and, classrooms and workplaces and the physicians, offices, doctors' offices is really needed. It's absolutely necessary at this point because it is becoming an epidemic.
But why? Okay, so I agree with you that we need to have this information, but what about dealing with the root problem?
And what would you say the root problem is?
I don't know. But I mean, creating pamphlets on telling people how to treat each other and what to do in certain situations that's dealing with the effect. That's not dealing with the cause.
I think it's not even just pamphlets and like it's teaching kids. I think it's important to teach kids about what good mental health looks like, positive mental health, what it looks like, so that they can know if something is wrong with them. And I think that should happen not only with the schools, but with the parents as well. Teaching kids about positive mental health. We talked about mental health last week, like mental health versus mental health and what that is and what that looks like. Having control of your emotions, your feelings, and your thoughts. When kids are out of control, when youth are out of control of their emotions, their feelings, and their thoughts, they need to have some type of marker to say, this is what positive mental health looks like. This is what negative mental health looks like. I'm in the negative category. I need help. Now, where do I get the help? Because kids are going into emergency rooms, they're talking to their physicians, and the physicians don't know what to do with them. And because they're so young, you can't just medicate all the kids. There needs to be another solution. You can't just medicate everybody. That's not gonna. That's a Band-Aid. That's a Band-Aid.
I think you just opened Pandora's box. I don't know.
Well, Pandora's box needed to be opened.
I mean, so we have access to physicians, but we don't want access to drugs. Is that what we're saying? I'm
not saying we don't want access to drugs when needed. If we can get them to the psychologist and the psychiatrist, and they feel that this is needed to help them get through their mental health, yes, then definitely. But if we could have some special, if they could go to specialists, like how I had my cognitive behavioral therapy, I need my meds because I'm bipolar. I have a chemical imbalance. But if I was depressed or anxious and I did some cognitive behavioral therapy, perhaps I wouldn't need to be on medication as well. It's different with someone who has a chemical imbalance than it is with someone necessarily who has depression and anxiety, and we kind of touched on that last week as well. But I just wanted to read a quote from that same article on mental health. It begins early after taking root in adolescence, yet we have designed a system that traditionally responds best to crisis. As if a wounded mind was a fractured hip. With mental health, however, it is essential to catch our young patients before they fall. So we're treating mental health like it's heart disease or diabetes or
that's what I just
cancer.
said. That's the point that I made earlier. The cause and treat the cause, not the effect.
Mm-hmm.
So what is the root cause? Everyone's
situation is unique. You don't know what people are going through in their homes. You don't know what they're going through at school.
So
some kids don't share. So you don't know. Like, you can't. The cause is it's every. I think every situation is unique. Like, you can't just make a blanket. This is the cause of mental health.
How are these these pamphlets going to be effective if we don't discuss or figure out what the cause is? I mean, gaining access to resources is a great thing, and we need to have that. And right now, you know what, the children are doing what they need to do, because at the end of the day, if the children are going to their doctors and the children are going to the emergency room, they're just not getting the answers, because, you know, today we live in a society with technology where you can get answers for most things. Mm. So when a kid asks a professional, who's someone they believe is supposed to have knowledge, and they don't get an answer that is acceptable, I guess is the word to say. Mm-hmm. I mean, that's troubling. I mean, I know I can go to my doctor and say I'm having this problem because, you know, I can go read WebMD, and I, as a person who's older than 25, I can process things and think about things and say, okay, you know what, when this says that, are you feeling anxious, you know, quote unquote, I know the difference between me just feeling anxious by the word, what it means in a dictionary, versus anxious where it's problematic, right? Like, I can kind of tell the difference between that, but we're not, we're telling everybody to take care of your mental health and such, but what's causing us to have all these problems today? Like, I think the access is actually really there. Like, people know where to go. People know I'm not feeling well mentally. So it's once they go to those places, the resources aren't maybe necessarily giving them the quality of answers or the quality of care that they may feel they need.
So I just want to, for me, there's several barriers to access. So we talked about poverty, stigma, lack of integration between mental health and other health services, shortage of mental health professionals, cross-cultural diversity, and at the end of the day, the demand exceeds the supply.
Okay, but all those things are fine, but I'm talking about what is the there's more demand today than there was 10 years ago. I don't necessarily think that there were so many people that were hiding it 10 years ago that all of a sudden now are coming forward with it. There seems to be an increase in people that are having challenges with their mental health. What is the cause of it? What really is the cause? Like, what is the cause so that we can actually say, okay, there is access. We're pumping money, like the government's pumping money into resources. You know, we're making the right strides, but we're working on the effect. We're working on, once you have a mental disorder, once you have a mental health condition or issue that we need to deal with, we're giving you the resources to deal with it then. But how are we working to get to that actual cause? Because I think that we do have access. There's a little bureaucracy, and, you know, you touched on that I think last week when we were talking about you helping out there. There's a little bureaucracy and such, but just from sitting back from my vantage point of someone who's looking at it, and, you know, outside of having you in my life, I don't really necessarily gain or lose anything from this directly, like in front of me when we're looking at it. I'm saying that there is more access today. You know, but we're not necessarily, now that we have the access, we don't know what to do with it, and we're not doing maybe necessarily the right things. Because if you're going to your doctor and your doctor's saying, look, I don't necessarily have the training to really diagnose you or help you, but what I do know is that this drug helps based on the symptoms that you are providing me and the information you're telling me and what you're saying to me, this might help you while we get you to see the person that you may need to see. You know, but you may not know exactly how to describe what's going on with you. There may be some issues there. As you said, there's some cultural barriers. There's some language barriers. You know, some in poverty. You might, you know, there's all sorts of areas, but challenges there. But I really think that we need to, like, look at what is the cause. Like, I don't know. And
I honestly don't know either. I don't know either what the cause could possibly be. I think it's technology. I think it's the world we live in today. I think young people are being bombarded with images and ideas and thoughts that we weren't necessarily bombarded with before. I think it's just having an effect on their mental health in general. And I don't want to completely blame technology, but I think that's like one of the aspects of it, especially when it comes to young people, because that's what they're on. They're on their phones. They're in their screens.
I think I'm going to take it one step further than technology, and I think it's the media and images that we see on that. Could it be? Because, I mean, here's the thing. We were all sold a dream, right? Like, except for me, when I was sold the dream, the reality, I'm still, like, as a man, I was always taught that you need to go out there and provide for your family, you need to make a living, and all that stuff. So, whether I'm doing that for a family or whether I'm doing it for myself, I still have to do it. Mm-hmm. So for me, living the quote-unquote dream versus living my reality, no difference. Mm-hmm. So I wasn't, like, even though I was sold a dream, the reality is still, I still have to do the same things. Mm-hmm. But then there was someone else that might have been sold a dream, like, I don't know, let's say Sex in the City. Yeah. You're sold that dream where you can go out there in the city, live by yourself, not have to care about anything, live that life. Well, living in the city... Drink martinis. Well, I don't know anybody that can afford to live in this city on their own and drink martinis in the bar.
Every night?
Even twice a week, right? Like, I mean, because I live in the city, and there's no way I can afford to go out and drink martinis anywhere. Like, that's not a reality. But I'm okay with that. But maybe someone was sold the reality of, hey, maybe I don't want to do this life, and I'm going to leave this life. And now does that create depression and anxiety? I don't know.
I think mental health isn't like cancer. It isn't like diabetes. It isn't like any of those other diseases, those physical diseases where we can properly analyze, chicken causes cancer, or like sugar causes diabetes, or, where the research has actually been done to see what is the cause. And that is the most frustrating part about mental health. They don't know the cause. Nobody knows the cause. I don't care what anyone says. Nobody knows the cause. But they're trying to figure out a cure. Right? They're putting a Band-Aid on an issue that it's a wound. As the quote said, your mind is wounded. And everybody's mind, everybody's brain is mapped uniquely and differently. And so how can you properly assess what the cause of mental health is? I think people are striving towards that, or they're working towards it, but I don't know how successful they're going to be because, as I said, everyone's brain, everyone's chemistry is unique. They can't tell me why I'm bipolar. They say that it has to do with genetics.
Well, no. I'm so that's fine. But I'm not. We delve onto the whole depression, anxiety to the side. So that's why I'm trying to say. No. So you're saying we need access to mental health care. Mm-hmm. I'm saying that there is access. I'm just saying the resources that we're accessible to. I don't want to say a lack of training, because I don't think there's a lack of training. I think there's a lack of maybe up-to-date knowledge based on the way that the average, look at it when it comes to the average consumer now, when it comes to buying something. Like, you go into a store now, you have price comparisons on your phone, you know how much something's worth, and you know if it's priced too high. You can easily say, well, I want to buy this, but it's priced too high. So if you bring it down to match this price that's on my phone, I'll buy it from you right now. Otherwise, I'm just going to order it here and I'll have it delivered tomorrow, right? Like, so. I don't think that there. I think there is some access. I think you have to. I think one of the key things when it comes to access is self-advocacy. Like I said earlier, if you don't know how to advocate for yourself, or you don't have. Let's say you don't have parents who, as we were talking about with cross-cultural diversity, that speak English, that understand what you're going through, you might not be the one to go into a hospital. And I'll give you the example of the young woman that I helped a couple weeks ago. Her mother is Spanish, and she did not understand what her daughter was going through. So she had to come to someone else, me, to discuss her issue.
and I took her to the hospital, so she had access because she had a friend who knew someone who is well-versed in mental health. But if it was just up to her, she would flounder. Kids are like, I don't know where to go and I don't know what to do. That's the messaging that's being given. I don't know what to do. I don't know where to go. And going to a physician, it could be helpful. Going to the hospital, sometimes not so much. Because look, they kept her for a night, then they turned her away because she wasn't in the catchment area, which is the area of your local hospital. So she had to go to another local hospital. So it makes it challenging. And this is someone who's having suicidal thoughts. Any minute, any second, any moment of the day, she could decide, I'm going to end it. I'm not going to do this anymore because she's not getting the services that she needs. This is the reality. I think the system is broken. I just completely believe it's broken. And it took, just to give another example, it took 10 years and 7 episodes before I got into my FACT team. The FACT team that I work with, which is extensive. Doctors, nurses, PSWs, etc., etc. But it took 10 years and multiple hospital stays, multiple different districts, multiple different areas for me to get the treatment that I needed that works for me. Some people don't have 10 years to wait. Some people don't have that kind of time. Some people don't have that kind of energy. Though they should, because it's their mental health and it's serious. But access is one of those things. I feel like it's accessible to people who have money and to people who have the means to understand the resources. But I don't think it's accessible to the average person. Like the average person that would, for instance, live in my neighborhood. It's not accessible. They're on wait lists. They're waiting and waiting and waiting for help. And sometimes help shows up and sometimes it doesn't. And that's just how I feel about access. I don't think mental health care in Canada is as accessible as it should be or it needs to be. And I know they're working on that. In 2017, they launched a access project where they have a 5-year plan to put $25 million into funding into this project. And they're trying to give people access within 72 hours instead of the longer wait times. And another thing they're trying to do is abolish the 18-year-old rule. Do you know what the 18-year-old rule is?
I typically like the 18-year-old rule.
Well, the 18-year-old rule is once you turn 18, you're considered an adult. So you don't fall under youth services anymore. Okay. So I'll give you an example because this actually happened when I was in 2016 when I was in the hospital. There was a young man. His birthday was within a few days of being hospitalized, and they had to move him once he turned 18 to another facility. So there was no continuity of care. So what this Access Project is trying to do is abolish that whole 18-year-old rule and have continuity of care between the ages of 11 and 25.
Well, I understand both sides of that one. I mean, you need to draw a line somewhere because you don't want to have... But do you want to have 11-year-olds and 25-year-olds being in the same... congregating in the same area for care? You don't want that. Like, you don't. Like, so, I mean, there's a line that has to be drawn somewhere. And in this country, we typically use 18 or 19 for whatever it is. Mm-hmm. And that's just the line. I mean, you don't want to. I wouldn't feel comfortable with 24-year-olds getting care with 17-year-olds. Mm-hmm. Right? Like I'm not comfortable.
And
with
they do. That's what happens right now.
Right. So I'm not. So if you're going to say that, okay, people under the age of 17 and under are going to be, cared for in separate quarters, and probably the younger ones even separated from that. I'm okay with that. I don't know. I think that's the right thing to do. I mean, it's all about perspective, but I mean, I'm looking at it from someone who's just looking at the numbers. But
I don't know. I just feel like the 18-year-old rule is one of those things because you're not a kid anymore, but you're not an adult. So I don't know. I feel like having some more continuity of care for someone at that age is probably a good thing. The services change as you change. Youth services are not the same as adult services. I don't think they're as extensive because, as we said earlier, it's youths are going through a lot of depression and anxiety, whereas a lot of the adult patients, they have serious clinical depression. There's like schizophrenia, bipolar. I was listening to the Nurse Elijah episode the other day, and he was talking about the fact that he mostly deals with in his FACT team, he mostly deals with adults that are going through things like schizophrenia, bipolar, and serious clinical depression. Whereas youths might not be going through that. Early onset for bipolar is like 24. So they might not even know that that's what they have until they're much older. And if you had more continuity of care, between 11 and 25, and then kind of shift them over, it's a solution. It's just, who knows if it's going to work. This, like I said, this Access project is a 5-year project, so who knows if it's really going to work. But I know their main objective is to have the early detection in youth and have access to high-quality evidence-informed interventions. So things like if you need cognitive behavioral therapy or any kind of psychological therapy, they're making sure that you have access to that earlier. Not necessarily within 72 hours, it's, I think, within a month. But that's much better than a 6-month to 1 year waiting list. So when it comes to access, as I said, I think the system needs help. I think doing something like a public service or campaign would be completely beneficial. As we said, I don't know the cause of mental health. I've never known the cause of mental health. That's not something that's in my wheelhouse. I'm not a professional. I'm not a doctor, so I don't know what that looks like or what that feels like to understand what the cause of mental health is. But I know that people are going through this right now. Our young people are really suffering. They don't know where to go. They don't know what to do, and they need help. And if we could provide them with the level of health care that they deserve, then maybe we could, because depression and anxiety, they're fixable, as you said last week. They're solvable. Those are problems that can be solved. They're not chemical imbalances in the brain. There's something that can be done and that can be solved. So if we get to our youth early and really help them navigate the mental health care system, I think we could see a drop in the number. Right now the number's at 20%. I think it's a lot higher. It's just a number I read. What do numbers mean anyways, really? But it's at 20% for youth with mental health illnesses and disorders in Canada. But I think the number is much, much higher than that. But we need to see a drop in those numbers because youths turn to adults and it's billions of dollars we're spending on things like Emerge, triage treatments, and the lack of follow-up after hospitalizations. It's all becoming too much. It's all becoming too much, and I think we need to really do something about it. I'm hoping that the work that I do with these two organizations that I'm working with can put a dent in some of these policies that are being created around mental health in Canada. I hope to actually do something at a grassroots level. That's my goal, that's my purpose, and that's my hope. So, J.R., do you have anything to add?
No.
Well, to all my young people out there that are listening, don't give up. Don't give up. Keep fighting. There is hope. Contact your doctors, talk to your physicians, fight for yourself, be an advocate for yourself, because access is not easy. Not everyone gets access, but if you push and you stand your ground, you'll win. You'll win. Mental health is not It's not a winding. It's a winding road, but it's a dark, dark tunnel, and there is light at the end of it. I found my light. It might go back to darkness at some point or another, but right now I found my light. I'm sure that you can find yours. So just keep at it, keep trying, and there's a lot of organizations in and around Toronto and in Ontario and all over that can help you. You just have to kind of do your research and see what best fits you. So with that said, that has been the dish of the day. JR, please tell them how they can reach us if they want to talk to us about access to mental health care, or if they need us to do any research on services. I'd be happy to do so. Let them know where they can reach us.
Absolutely. You can reach Onika at dysh, dysh, at daintydysh.com. You can also check out her writing at onikadainty.com. You can also check out our website. It should be up finally at daintydysh.com. DAINTYDYSH.com. If you're listening to us on Apple Podcasts,
give us 5, deserve 5.
Oh, we truly appreciate you. Thank you so much. Subscribe, that's great. Thank you so much. If you're listening to us on YouTube, give us a like, subscribe. If you're listening to us on SoundCloud, we truly appreciate you. Thank you so much. And that's it for me.
All right, like I said, that has been the dish of the day. I hope y'all have yourselves a very, very, very happy hump day.